everybody. This is always an interesting experience for me in this webinar format because I cannot see your smiley faces, but I feel your smiley spirits. Welcome to the third part of our ethics series on AI. And during this time, I'm going to be going over more of the clinical implications for practicing AI in the field. And I am also going to be sharing some of my experiences in the past year working as an AI consultant. I'm getting my slides queued up right now, but many of you know, if you've been in a presentation with me before, that I really enjoy interactive work. And so I hope that we can make this interactive even though we're in the webinar format. And if you have any feedback about that, you can let me know. So I often use a platform called Slido to interact as opposed to using the chat. Um, and so today is going to be no exception. In keeping with the disclosure elements that are relevant for the use of AI, I will disclose that I looked up the privacy settings for Slido. So just so you know, Slido does capture some bits of your information just for the purposes of interacting with the presentation today. Very similar to the ways that Zoom captures your email and your name when you join a meeting. You can opt to remove your information from Slido at the conclusion of the presentation, but also I just have this set up to work for the next 2 days, and the only thing that it sees is the only person that sees it is me and Slido to run the program. And so if you're comfortable with that, and you want to interact in the presentation today, I would really appreciate it if you would either go to slido.com and put in the code UCEBTAI, or you can scan the QR code and it should pop up that way. So to test people's, no, just kidding. I put that stuff later on. I'm going to introduce myself first. My name is Dr. Kimberly Applewhite, and I am a licensed clinical psychologist. Currently, I am the Dialectical Behavior Therapy Program Director at Utah Center for Evidence-Based Treatment. And I have done ethics trainings before. If you've seen some of them, they are generally about different aspects of intersectionality and cultural competence as it relates to clinical work. And I do think that the AI discussion is relevant to cultural competence for reasons that I will get into later. I also, like I mentioned, am currently working as a consultant on an AI-powered mental health support app. I also would consider myself a casual AI user, so probably my proudest accomplishment using ChatGPT to date is coming up with a church-approved 90-minute version of Spring Awakening. And so I didn't know how to say, I just use AI for jokes. Many of the applications of AI in my life are, can you make a chore chart for my family? Can you tell me how to send this email and make it shorter? Just pretty basic things. I'm just gonna, so yeah, not a lot of clinical applications for AI that I was engaged in before I became a consultant on the app that I'm working on now. Um, so just to go over just these things that we go over before we start a presentation. And it's important to name because I do work as a consultant for this app. There's no commercial support for this presentation, and based on that, it's not like they like pull my arm to make me do it. There's not like an official conflict of interest to report, but I will observe many times that I am working for this app, and so that will probably bias my perspectives to some degree, and you're welcome to highlight that for me if you notice it. The risks of attendance are minimal, but it is important to be mindful that you receive additional supervision and training to implement some of the things that will be suggested today. Professional ethics will primarily be discussed through APA and social work codes. So just be mindful of your own professional codes. I try to put the others in there when I can. They're in my notes, but in the slides, it'll mostly be referencing APA and NASW. And then research and skills may not apply to all populations, so the limitations will be noted there. And so these days, we also are tasked to disclose the use of AI. I have to be honest, guys, I do not remember if I used AI to generate the title of my talk. That sounds like something I would do, but I don't think I did it this time because of the Rage Against the Machine collaboration against the machine juxtaposition. So I'm just going to go with saying there was no intentional use of AI. If you attended the other presentations, Dr. Rowley and Dr. Ertl both generated AI scenarios, but they disclosed the use of AI. I didn't do anything like that, but many of you will note that these days when you go to Google, when you open your email, there's all kinds of AI-powered things. And so I really did try to be diligent and not attend to AI support in those search tools, and it might still have impacted some of the results. Also, side note, it's really hard to read a lot of first-hand material and not read AI summarizations of the thing. Just to name what may be unnamed. But as far as I know, didn't use any AI to generate the content of the presentation. Unless Dr. Rowley used AI to come up with the template of this slide. Anyway, I don't know if I did. So the learning objectives for today are hopefully by the time you leave, you'll be able to adequately describe pros and cons for AI and mental health. You'll also be able to describe ethical dilemmas for therapist involvement in AI mental health development. Cool. All right, so here's your first Slido test. So if you joined, great. If you didn't, the code is here. Because I cannot see you, I would love to know who is here today. I'm a psychologist. Apologies for my bias there. I love all the fields. But yeah, just let me know who is here today. I don't remember if I set this question to give more than one response, but thank you to whoever is a fan of mine that is here today. That makes me feel good. Also, if you didn't mark that, don't feel pressure to mark it now that I've mentioned that that is reinforcing to me. Lisa, thanks. Yeah, so we've got psychologists, social workers, mental health counselors, other mental health workers in the house, and like my fans, we got some trainees. This is awesome. I would love to know what the other is if you want to say in the chat. I didn't give it as an option for a fill in this time. Cool deal. So I want to know, so some of you may have been with us for the other two parts, and some of you have not. I'm wondering, like, right now, today, how likely are you to incorporate AI into your clinical practice? We got marriage and family therapist. I love that. Thanks, Ashley. My meeting controls are really on one, and so I am not able to see how many. Oh, yes, I am. I've just got to move my face so I can see how many of you are responding. Got 12 responses so far. And let's just see, how likely are you to incorporate AI into your clinical practice? 21% of 14 is what? 2 people? Say not likely. No, it's 4 people. Don't test my math this early in the morning. Um, and some of this is fitting the trends of other fields. Some research from the American Medical Association showed that overall, physicians or medical professionals in that field are turning to AI kind of at an exponential rate. So from 2024 to 2023 to 2024, they saw an increase of, I think, 80% of people saying that they would be likely to incorporate AI into their practice. And that data is showing that for a lot of people, there's only some who feel like the concerns about AI do not outweigh the benefits of AI. Many people are proceeding to incorporate AI while they're still weighing the pros and cons of that. And I think that that is a relatable place for me to be as a provider, and hopefully that resonates with some of you. How likely are you to make AI participation a part of your professional role or identity? So this is referring to, we can build our identity on all kinds of things, good, bad, or indifferent. And so some people are comfortable with a future in which we, recognize the impact of AI, but didn't get so much into it. Other people are like on the opposite end, and they kind of embrace where AI is going and acknowledge the importance of being along there with it. And then some of us, like I was saying before, are kind of in between. And so the people who responded to this are saying, I'm not really likely to make AI participation a part of my professional role or my identity, which is cool. And I'm not going to try to change your mind, or hopefully you don't perceive it that way, but I will kind of take a stronger stance in terms of why I decided to get involved with AI initiatives at this point in my career. So we'll do some brief reflections on part one and part one, on part one and part two, and then we'll kind of cover the current AI landscape, and then I'll tell you about my experiences, and I'll try to frame it using some of the ethical principles that were discussed previously and some that I've added, and also roughly using models of ethical decision making that were introduced the last time that we all gathered here. And then we'll just talk about some ways to think through clinical and ethical dilemmas related to AI. All right. So, in case I haven't said it enough, this is part 3 of this series. Part one was given by Dr. Rowley about a month ago, and that is the title of it. And then part two was given a couple of weeks ago. Both of these are already on our YouTube channel if you want to rewatch those and not receive CE credit. But if you do want to receive CE credit, you can go back in some way and register for those. And so if you feel like you're coming in the middle of the story, don't worry, I will try and catch you up a little bit. So in part one, Dr. Rowley gave an amazing overview, not only of what artificial intelligence is, but what some of the pressing issues in AI are now, especially as they relate to therapy, including a lot about privacy concerns, who is getting the data that is being used, who are they selling it to, what are the regulations around this, bringing up the potential for bias. And so there's a lot that people think that they can accomplish with large language models and synthesizing information, being able to produce it. But there's also bias present in who is training the models to do this stuff. And sometimes the responses that AI learns over time develop their own bias. Really, the development of AI is susceptible to a lot of the same things that the mental health profession has been susceptible to for years in terms of looking at who's at the table when these decisions are being made, and that the production of things going forward is going to heavily depend on that lens. She also touched on the environmental impact. There is a lot of media around how much water, how much energy is used for these like large data sets and processing. Interestingly, I went, and I'll bring this up later, I was watching the TikTok tale of the person who was in love with their psychiatrist, which maybe some of you have heard about, immaterial. But um, one of the things that she mentioned when people were talking to her about environmental impact is that we all make choices about what we choose to sacrifice for the benefit of what our value drive is leading us to do. And I won't say broken clock is right twice a day, but there's a lot of kernels of truth in that sentiment that, like, many of us take flights, eat meat, do things that have environmental impact already. And one of the things that Dr. Rowley talked about is if we as mental health professionals understand the value of large sets of data, would we opt into smaller sources of information for AI generation if that like increases the likelihood of bias or some other thing? And so even with environmental impact, there's still a lot to consider from a clinical perspective on what we are willing to sacrifice for in this period of time. And then she touched on the patterns of AI use, particularly how clients use them, but also how therapists use them, could present possibilities for harm, misinterpretation. A lot was said on how AI tends to be more validating and how this presents challenges from a clinical perspective. But then she also presented the view that AI is here to stay. So the title of the presentation was "It's happening whether you want it to or not." And indeed, it is. So that's part one. And then in part two, Dr. Ertl talked about ethical decision making. So when therapists are trying to navigate whether they will use AI for clinical endeavors, what are the steps that we use to evaluate that decision? So he mentioned that he is piloting using AI to write notes. That is something that was way appealing to me for a lot of reasons, but then less appealing for others. And so um, other reasons, I mean. And so we can, like I often say in DBT, when we're weighing interpersonal factors to consider, a lot of times, like if you just think of one thing or another thing, um, each one of those factors become the biggest thing in your view. And when we're using a skill or a tool to help us to sort through that, then each of those individual factors just become um, kind of one part of an additive decision-making process that helps us to calibrate what our next steps should be. And so ethical decision-making models, like the ones he presented, give some uh, room for us to think about, like, how do we interpret information? How do we formulate an initial action step based on gathering an awareness of the facts? How do we weigh um, personal biases or other values that we hold that may be interfering with ethical decision making? And then how do we take all of that information and put it into a plan? So part two covered just thinking through this for note taking, for report writing, for a couple of other things. And so, like I said, those are accessible on YouTube. You should check them out. Um, but I want to know, what questions about AI in clinical practice do you still have? Um, the way I tend to prepare for things is by reading a lot of stuff, and I'll tell you what I know. So if something is not covered in the slides, I still want to know um, what questions or curiosities can we discuss. So take some time. Let me know. Thank you, the two participants who were typing. Um, and I will also, oh, I forget how I pull up the meeting controls when I've already let go of the meeting controls. There they are. Um, just gonna pull up a chat in case inaccuracy of information is my biggest concern, as well as clients' privacy. This is really valid. Um, I've been thinking about this a lot where, oh, I did mention my proudest accomplishment for AI, but I did one day experiment. So, some of you may know that, like, I'm pretty active in my faith community, and I was giving a presentation at a conference there, and I was supposed to be talking about uh, pillars of my faith, which is why I bring up it was related to my non-work life. And so I entered into Chat GPT. If this is the theme of a talk that Kimberly Applewhite, my married last name, is giving, what would she say? And I'm telling you, Chat GPT really gave me like an assessment of what I would say in the situation. Oh, Kimberly Applewhite's a psychologist that really incorporates social justice themes and authenticity into her. It was really wild. I did not use what they said. I think that they, speaking of bias, had put too much Black church preacher cadence into my words, which I do not have because it's not a part of my context. But uh, they really read me in a lot of ways. Or however, I don't want to name AI. Anyway, so we've got some questions. Do we really have the choice to opt out of AI utilization? I don't know. How are we not understanding how AI helps therapists with disabilities continue to practice? This is really valid. It helps therapists, and it also helps clients to be able to access things. And so on the other end, we have like the ethical responsibility to represent our work accurately. And then we have client concerns of AI psychosis and stuff. So yeah, I read that question as like a larger discussion of how can we balance these benefits with the risk. Inaccuracy of information is the biggest concern, as well as clients' privacy. Do y'all remember Wikipedia back in the day? Like, it was so inaccurate and everybody cautioned us against it. I don't have a poll that asks how many of you are using Wikipedia now, but I think that we probably have learned some um, educated and informed ways to interact with sites like that, knowing what their limitations are. And so I'm wondering if we can do something similar to or with AI, or have we do we have this belief that large language models are infallible in some way, even though we know that they're making mistakes? And how do we keep up with so many ongoing changes to AI and tech in general? Feels like if we adopt some practice today, we might have to change it tomorrow. Melty face, indeed. Yeah, we can get into that later. Thank you, whoever entered questions. So I'm going to go over some trends. I already mentioned that, like in some other fields, we already have research on adoption of AI, and we know that um, uh, professionals in the mental health field or in the healthcare field participating in mental health is much higher than it was before. That AMA survey that I referenced says that 66% of doctors are using AI. And actually, rather than calling it artificial intelligence, the AMA prefers the term augmented intelligence because it reminds us that there are often still real humans involved in the development of artificial intelligence. So it's not just machines. In the case of healthcare, it's physicians, therapists, whomever, helping to teach the machines, hopefully. Sometimes it is just software developers and people with their own interests telling the machines what to do. So anyway, wait. Hi, my trolls. Oh, let me see if I can do this. Oh, yeah. I was like, where's the quiz? Here it is. The 15 of you that are participating so far, I really appreciate it. The others of you, if you don't want to use the Slido, that's fine. But I do want to hear it in the chat. When do y'all think the first AI therapist bot was created? This was new learning for me. Let's see. I wish I had prizes to give you, but we're virtual. We're already starved for in-person connection. All right, I'll give you half a Trebek, and then we're gonna reveal the response. I hope when I click on it, it will do it. Okay. All right. So most of you thought, I don't know how to interpret this. My mind is tired. Many of you made lots of guesses. Nobody thought it was the 80s, which is what I was thinking initially. So now you all know that that's not the answer. The answer is the 1960s, the 1970s. Um, and so they created a machine to test Alan Turing's hypothesis. That's like the imitation game guy, I believe. Um, in the 50s, he thought, and really they were working on some what we would understand to be the beginnings of artificial intelligence in the 50s, but the first one that was designed to respond like a therapist was in the 60s and 70s, and somebody made a bot that would follow Rogerian principles and be able to just provide some basic empathic responses and engage in some learning. Um, and the person who did that's name is Joseph Weizenbaum. But the Turing test was to just this idea that like um, we have some innate capacity to tell humans from machines, and past a certain point, we're not going to get as good at doing that. So Turing speculated that by the end of the century, um, that we would be like 70% good at it, telling when something was machine versus when they were human. And some of the recent research says that we can do this. Oh, congrats, Meg! I just read passed by that. Don't I didn't want to miss giving you your flowers. Um, but the research says that probably people are good at detecting human or machine like half the time. Uh, which tracks with Turing's hypothesis, but probably should frighten all of us to some degree. Those of you who attended the part one of our presentation got some tests with this, with Dr. Rowley asking which vignette was generated by AI and which was generated by a therapist. And some of the linguistic patterns that were identified were like they use more nouns, they use more adjectives, they use more verbs. The response is often longer. Um, Even in Dr. Ertl's talk, when he prompted AI to write a vignette, it was like the rain was streaming through the windows and whatever. But I don't know, like people are into that. I'm kind of mad because I tend to write really long exchanges, as any of my coworkers will tell you. And I am often told not to do that. But joke's on all of us. A lot of people, when they are tested or like polled, people will lean toward AI messaging because it is longer, because it maybe uses more descriptive terms that makes the speculation from these authors is that it makes people feel more seen, or the potential to be heard and understood is greater if you're using more nouns and adjectives, which might be translated into contextualization. Whereas um, maybe other professionals, when they respond, don't tend to do as much of that in our written response. So in this study, which I'm so pleased to say, one of our former trainees at UCBT was on this paper, and a couple of people I know. So shout out Russ Bailey if you are here. But so this research came at the primary author is at BYU, I believe. So they had therapists write a response to a clinical vignette, like a group of, I think, 19 therapists it ended up being. And then they also had ChatGPT to respond. And then they gave these vignettes randomly assigned to a group of people. And they were asked to identify which responses were written by ChatGPT and which were written by a therapist. And then they were also asked to rate the responses, not just the therapist, but the chat GPT responses as well, um, on these 5 factors that are associated with the common factors that lead to good therapy outcomes. So like alliance, empathy, expectation, cultural competence, and therapist effects, like of a good therapist. This sounds like something a good therapist would say. And so people were pretty bad at it. So they could only guess half the time. Uh, I am glad that people could tell that it is a human more with like more accuracy. And the difference is significant, but the effect size is small. That has something to do with how few therapists there were in the study providing the vignettes. But then the responses written by ChatGPT and misattributed to therapists were rated higher. So they showed in this that like if the person thought that the person was a human therapist, they tended to rate the responses higher. So in that, ChatGPT responses got rated higher if the person thought that they were a therapist, followed by accurately determine therapist responses. And so that tells us something about what people want to hear from us. Another thing to consider in this is that um, when you tell a therapist to respond to something, they respond as themselves. There's no telling if you received a vignette in your email tomorrow that you would be like, oh, let me look up this article on the subject, or oh, let me like go consult about it. But essentially, when you prompt ChatGPT to act as an experienced therapist, it's pulling from several sources of whatever it has learned, multiple Googles of several, to generate a response. And in this case, the ChatGPT was specifically told to respond with common factors in their reply. And so, how often do we, as therapists, have that level of specificity in our responses or level of intentionality? So, it is something to consider that, like, we don't really have or regularly engage in a human analog for prompting in the way that ChatGPT does. Nevertheless, people like it. And so, what do we want to do with that? Do you guys have reactions to this? Either put them in the chat or put them in Slido. Wow, that's crazy. The machines really are going to get our jobs. What does knowing that people prefer the responses of a chatbot to a therapist do inside? I would love to hear. And yeah, if it's faster for you to participate in the chat, go ahead and do that. You can maybe guess. Thank you, Mona Lisa. It is interesting. And yeah, it's something. I don't know why it's concerning for you, but it's concerning for me because I tend to put a lot of weight in perception for a lot of reasons. And so I do have concern about perception of non-human interaction being more effective for sure. Pulling from quantity of info doesn't equal quality or accuracy of info, which is totally true. Yeah, I think this is where AI prompting comes into play because they can have more specificity. But then, like we talked about in part one, there's still a lot of things that need to be checked for accuracy. But then people liked it. So we can say what we want, but people prefer the bot. Uh, it's not that surprising. I'm curious why, in the world of being interested in people's genuine emotions, it is a bit scary. It makes me wonder, like, what we miss, um, because, like, humans are evolving. Like, we know from, um, anxiety research and just watching trends, people have more of this evolutionary drive um, to go toward human behavior or perceived threat from human behavior. And in that, what kind of patterns have evolved in speech and language and whatever um, that people perceive as threatening? Maybe some of these things machines don't do, or maybe some of the reinforcing elements of social interaction the machines have picked up on from these large trends. Um, the novelty of AI is temporary. There's a huge part of therapy that's based on client-therapist relationship, which AI cannot mimic. I think that there's a lot of value in that. There was a KUER article that one of my good friends, Dr. LaShawn, commented on, and she's like, yeah, the AI might be better at it, but like sometimes like our clients just need a Gatorade and a walk around, and AI can't do that yet. And so there is not only in like the physical elements of things, there are felt qualities, hopefully, to human interaction that are just different. And ultimately, like we live in a generation where people are very used to interacting with machines. We're used to making assumptions about what's more valuable, like what kind of language helps somebody to know that somebody is competent, smart, and all these kind of things play into how we interact with machines. But then human interaction takes different kinds of nuance. And so we don't really know if like a human interaction, like a human that knows a human rather than a machine interpreting a human, will lead to better effects. Yeah. Thanks, guys, for interacting on the chat. So there is a review done of different trends in mental health AI. You go and read this article. It is like wholly positive. They are like AI is the best thing since sliced bread. And I at some point I was looking for the M dashes or whatever because I was like, was this written by AI? Like, where are your disclosures? But anyway, is public health authors. And so even that contextually makes sense for why people in the public health field are so excited. Because the main thing that they cited as concern was that, like, we have a global mental health burden that just keeps growing year after year. And if we think that conventional approaches are going to get at that, we're kind of kidding ourselves. I have, I hope, really great one on one impact. I am limited to 20, if that, one on one impacts a week in a therapy setting, which maybe translates to like considering like recurrences, 40 people a month, maybe 35. And so just one person doing it at scale or like 50,000 people doing it at scale is not meeting the demand. Like we all are not, even though many of us, I'm sure, are practicing in telehealth, there's still barriers to entry for people in rural areas and minority communities, people that speak other languages. Spanish, which is one of the most common, I say this one often in my um, presentations. Let's say 6% of psychologists speak Spanish. At some point, it was 5.5%. And so, even with Spanish being super common, we as humans have only so far that our impact can go as individuals. And so they talked about how we have AI driven tools that have made all of these strides in analyzing speech, text, facial expressions, and all of this can kind of go into some predictive data that helps people identify when they're at risk. Did you know? I mean, like, this hasn't worked for me. I guess because Google's figured out that I'm a therapist, and when I look for things, I'm not in trouble. But in some countries, if you search for items related to mental health systems, Google will like analyze those searches and previous searches and pull up like the PHQ-9 or the GAD-7 or like I didn't check the PTSD screener that they use. And so they are using like a greater depth of data than sometimes we as therapists have access to. And so it's something to consider. And digital entities provide around the clock support to individuals with mental health concerns, and it doesn't matter where they are, what time it is. As somebody that does DBT work, this is probably the main thing that draws me to being interested in what AI can do. We run a comprehensive program here, but one of the places that we have flexed is providing 24-hour phone coaching to clients. My personal boundary says I really try to respond within 24 hours or like in a 24-hour period if I can, but then people are getting me when I'm tired, when I'm hungry, when I'm with my children, when I'm in another place. And sometimes that affects how willing people are to reach out to me, even though we do a lot of coping ahead in session with how to navigate that. People still have hesitation to reach out. And like the facts of the matter are, if you text me at 11:47 at night while I am putting the final touches on my presentation, I may not give you the best response. That's some of the informed consent that we, I think, imply or provide to clients, but it's something that potentially could be eased with the burden of AI. So this article talks about all kinds of AI bots that are out there, and how they have been used. And so we have, Dr. Rowley also talked about this in her presentation. There are chat bots, like the app that I work on would be considered like a chatbot based. I don't think that they would call it therapy. Their role is triaging to therapists, but there are chatbots that are designed as like mental health entities. There's also just your run-of-the-mill apps that probably use some kind of AI in the design of them, but they're not actively like integrating data. And then there's some other ones that were not originally mental health tools, but have been used for mental health purposes, like Watson, for example. You remember IBM's Watson from like, I don't know, it was in my lifetime. So let's say 20 years ago, is one of the entities that has learned to early detect Alzheimer's, for example. And so they use the different tools that they have to be able to flag when a therapist should be concerned. And so there is some promise there. We can have more reactions to this if you want. I'm observing that it is slow for people to get, well, not slow, that's a judgment. I I want people to feel like the time is valuable. Again, I provided the informed consent that I often prefer to have interactive presentations above just talking to people. So the webinar format has presented some challenges. But yeah, if you have thoughts at all, you can put them in the chat, or when I bring the Slido back up, you please react. I'd love to hear from you. And so I'm going to tell you about how I became a consultant for an AI-powered mental health support app. Okay, so as I mentioned, the title of this presentation is related to, I don't know, I thought of Rage Against the Machine, which I like barely know. And I'm like, why rage when you can collaborate? Yeah, no. So Dr. Rowley mentioned this quote from Jessica Jackson, and this is a photo of Jessica Jackson. She looks like a boss, doesn't she? In the article in the APA Monitor, she says a lot of people get resistant, but this is something we can't control. It's happening, referring to the advent of AI and mental health. It's happening whether we want it to or not. If we're thoughtful and strategic about how we integrate AI, we can have a real impact on lives around the world. So that was her in 2023. This is her in 2025 saying, as psychologists, we have the responsibility, the opportunity even, to guide and shape the future of mental health. We do not have to observe this process of development from the sidelines. So I will note that even Dr. Jackson from 2023 to 2025 went from a therapist who her main focus is in providing equitable care to communities of color, but also had, I would say, an amateur interest in technology, to in 2024 heading up clinical initiatives, or being on the clinical advisory board for Modern Health, which is one of these platforms that some of you may use, that their employee assistance programs that some employers will buy into, that allows people to access therapy and coaching. And she was kind of the technology advisor at Modern Health. And now she is, I wrote it down, she's like a technology advisor in the government. And so, judgments about different administrations aside, that is quite an arc for somebody to go from a therapist to being the chair of an advisory committee. I found it. She's the chair of the APA Mental Health Technology Advisory Committee, and she's on the U.S. Food and Drug Administration Digital Health Advisory Committee. So that is really interesting to me. And then I have uh, our lovely marketing person's favorite thing, a surprise video that I did not tell her I would have in here. Um, this is another one of the things that really influenced me to think broadly about how I wanted to expand my career. So I was a postdoc at Boston Children's Hospital. So had an instructor appointment through Harvard Medical School to work in adolescent medicine division, and Dr. Jessica Henderson Daniel, who is president of APA, and I want to say 2016, was my supervisor. And she, you look her up, has all kinds of accolades. She, I don't know, she was like the first Black woman PhD at Harvard, I believe, probably the first Black person in the division of adolescent health. Um, and so I really looked up to her a lot, but I'm laughing because when I asked her about what it was like to work at Harvard, and I don't want to speak ill of our greats while they're still here, but like Dr. Linehan, Dr. Daniel is dealing with like end stages of dementia and stuff. So but I think she would be okay if I shared this with you. When I asked her about working at Harvard, she's like, man, I hate it here. Like, she did not enjoy it, but she stayed because she valued psychologists really being present where the work needed to be done. And in settings like Harvard, like Boston Children's, where you have an opportunity to provide unique perspectives that would benefit diverse populations, she just made it a professional goal to be there. And so it's something that I really value and have taken into my professional identity. So I want you to hear her talking about what it means to be a citizen psychologist, which was one of her initiatives while she was president of APA. That thing. I hope you understand, yeah, why this woman would be so meaningful to me. This is just a crucial part of my identity, recognizing that we miss so much when we are not accessible to everyone. So think of the problems that could be solved in our world if people were healthier, if people had access to information about how to make better connections with people, how to improve their relationships, how to improve their mental health. And then how easy is it as a person with an advanced degree to believe that you have all the answers when you don't? So citizen psychology, when she was president, was about a lot of like human relationships, but I attune that or connect it to um, getting information from diverse sources, including technology. I had another slide, but I can't find it. So we'll just read this. I also am really anchored by the principle of justice. Um, and so it says that psychologists recognize that fairness and justice entitle all persons to access to and benefit from the contributions of psychology. Psychologists exercise reasonable judgment and take precautions to ensure that their potential biases, the boundaries of their confidence, and the limitations of their expertise do not lead to or condone unjust practices. So this is something that I think about quite a lot. Along with this, because psychologists' scientific and professional judgments and actions may affect the lives of others, they are alert to and guard against personal, financial, social, organizational, or political factors that might lead to misuse of their influence. And so I mentioned to you that well, I mentioned a faith community, and if you have gone to one of my presentations before, you know that I'm a part of the predominant religious tradition here in Utah. I did not grow up with it being predominant since I'm not from here, but it has been something that's guided my value system for a long time. And so when I decided I want to be a therapist, I often thought about how overwhelmed I was because I hadn't actually experienced some of the things that I was interested in helping people with. So like I've never used substances, so how could I advise on substance use? I've had an intact family in a two-parent household, like dual income, um, middle upper middle class. There are just a lot of experiences that I've had that I wouldn't trade, but they shape and indelibly my voice as a professional. And what does that mean when I go and work with people who aren't of my faith? In Utah, many of you who are on the Utah therapist page know that it's like a regular thing for people to request LDS or non-LDS therapist. And it's understandable because I think the stories that we have around what people in big, powerful systems will do is abuse. But for me, I was just more concerned about what are the things that I don't know because of how I've lived my life, which I think I hope that everybody to some degree ask themselves what lenses are they missing because of how they were um, born or what circumstances they've inherited, because I feel like that um, leads to an informed and aware professional that can um, see where their biases come up, and they don't have to be negatively valenced or evaluatively bad to be biased. So yeah, as somebody, as a part of my faith is something that I've always thought about. Um, Also, for competence, APA has these standards of um, uh, we practice within the bounds of our competence. Uh, and so we try to study and gain education so that we can be competent people. If there are areas where the standards don't exist, we still try to learn about them. Um, and we do that work, we establish competence based on professional knowledge. And so when you take something like a fear of what machines will do, I check that against the responsibility I've taken on as a psychologist to base that on what the literature says and not just what my internal compass, for whatever reason, says. Um, I also value contextualism, and like I value it so much I've already like given it away. So there are other psychological associations for people in different minority communities. Um, and I am actually not a part of any of them except for Division 45 of APA, which is on research for ethnic minority issues. But when I went to an Association for Black Psychologists conference for the first time about 10 years ago, I realized that there were these principles that were kind of woven into what attracted me to being a psychologist. Um, and so I've pulled some text from other psychological associations just to highlight things that I have already felt ground my experience. So ABPSI has this principle of ma'at, which is about rightness, that there's not really um, a lack of relative truth, that there is still some orientation to what can be done to make the world right. Like there is actually a perfect way for a flower to bloom. There is actually a perfect way for a building to be built. There is actually a perfect way for somebody to be a psychologist, for somebody to be a healer. And part of my commitment to myself as a Black woman and to the Black community is to continuously practice this principle so that I'm continually improving myself. And ethical practice isn't just about avoiding consequences, but about creating a higher level of moral consciousness in yourself and in society. So for me, that means like oftentimes in my life where I feel like it is easier to not engage in certain issues if I don't know about them, don't have the time to learn. I mean, like setting up my kids' cell phone is a great example of this. Like, I don't know about like all these settings and stuff, so it's easier to just avoid them, like avoid doing it, or I don't want her to get mad at me, so I'm not going to set this limit. Um, on a practice level, I am working to make life better, just like I am in most of my relationships. Psychology of Indian psychologists, which is really for native people, um, make this point that ethics are influenced by prevailing sociocultural context, and we run into trouble when we assume that ethics is a universal thing, so that there aren't any provisions made for cultural differences. So this has come up quite a bit in deciding to do any number of things I think that I have done as a Black psychologist, psychologist of color, Black woman, psychologist, whatever that intersection is. It it often leads me to want to connect with people in different ways than maybe some of my colleagues do. Or I might be more willing, this came up even in consultation team the other day, I'm often more willing to not engage in multiple relationships, but entertain the possibility that these are possible because the communities that I'm in are so collective that it's almost impossible to totally avoid people that you know or somebody who knows you. And so I manage that, but I also have different boundaries around it. And so it influenced my decision to be an AI consultant, mostly in the way of um, recognizing that what I might do as an ethical psychologist is defined by my context. And when people disagree, it's not that I don't take the feedback in, but it is also based on what their ethical constructs are, what their context is. And so it's not always going to be a universal answer. And I hope that that's been clear if you've been to the other two parts, that there are no universal answers for things like this. But um, we just try to orient the best ways we can. Um, and then the National Latinx Psychological Association talks about a lot of things, but it it mentions that interpretations can facilitate or hinder the ability to see ethical dilemmas, and so they have this principle of like valuing process over content and maintaining a responsibility to be both a keen observer and an open-minded listener. So for most things, I try to like just watch what it does. It fits with my orientation as a DBT therapist to like try things and learn things. Like everything is data. If it's not good, we can walk it back. And so these kind of influence my professional identity. I'm curious, what values ground you in your professional role, or what informs your approach? Go on ahead and share either in the chat or inside though. You can tell maybe that I'm not the type of therapist that tends to do well with silent pauses. We all have our growth areas. But yeah, what values ground you in your professional role? Making lots of money, having lots of power over people. If those are your values, I'm not sure if that you're you found the most efficient route to that. Just kidding. Well, apparently nobody has values that ground them as a therapist, and that's okay. I'm just joking. If you have thoughts on this, just put them in the chat, but I can move on. Oh no, it came. Maybe you guys were just slow. Not slow. Maybe I was slow. Thank you. Blame technology because that's the moral of today. Empathy, diversity, resilience, intersectionality into these things. You also don't have to, not that you can read my mind, you don't have to name things that I would like. But I do like all of these. Uh, Justice, resilience, becoming a popular answer, willingness to learn, love. I feel like I share that as well. Oh, we have more anti-racism. If racism was a value of yours, coincidentally, you would be at home in some degree in mental health fields, but I'm guessing that anti-racism was meant. Don't clarify it. You're okay. Egalitarianism, harmony, curiosity, humanization, empathy, inner reflection. Ooh, I love it. Uh, Collaboration, into it. Clients, you like people. I'm in. Thank you all for sharing. Um, okay. So here is the background. Uh, so I attended APA convention in 2023. Jessica Jackson was actually a speaker there. This was when she was in her modern health position. And so it got me thinking about AI as a possible mental health frontier. We get these monitor magazines, and like the front cover is often like, is this the next frontier? Is that the next thing? And for whatever reason, I think I was also like mid um, uh, like career change, I guess. I'm coming to the end of my early career time. That was also when I learned that I would be accepting the current position I'm in now as DBT program director. And so then I do think that my mind was kind of attuned to saying, okay, well, what's next? Like, how can I build? Um, so yeah, so one of the first things I did in my new position was try to step up the amount of outreach and professional speaking that I did. And so I participated in an educational convention as a DBT influence mental health professional. And because of that, I was connected to somebody who was developing an AI app. And so they said to me that they're working on this app. It's going to help with mental health in schools. Um, I feel like it really has promise, the developer said, especially if you're into DBT work, like something like this could help with your coaching and um, just really get in on the ground for uh, kids who were struggling. And so these were all things that were reinforcing to me at the time. And so uh, from the time I talked to him to the time I became a consultant was about 6 or 7 months. Was that intentional? I wish it were. It was not. However, it gave me a lot of time to reflect on what were the relevant factors or what would constitute ethical decision making. So Dr. Ertl talked about one decision making model in part two of the ethics presentation, and there's others, but many of them just get at this idea of looking at what the issues are, who's going to be affected, what are the ethics involved, and who can you ask about it before deciding to implement a plan. And so one of the things that I or considered was this professional responsibility to engage. Um, the older I get, the closer my own kids get to teenage, the more that I am aware of limitations in traditional psychology models. There's only so many people you can help at one time, especially as my kids are doing activities at the same time that teens need to come and see me. And so I have been struggling with the professional responsibility to engage in a way that is consistent with the degree I earned, but also fitting with the time that I had. I also, considering in my professional responsibility to engage, is all the things that I already shared with you about how ethically I feel like I have a, a, a task to better my community and things like that. I see a hand. I do not know how you can ask the question, but put it in the chat and I will answer it unless you raised your hand by accident. Jennifer, help me. Okay. While we're deciding if it is a, oh, wait, I can check one more place. I do not see any questions in the Q&A. So, friend, if you raised your hand on purpose, just put your question in the chat or in the Q&A and I can see it. But otherwise I will. Oh, it is intentional. I don't know. Jen, if you could help me answer this question, I would appreciate it. But then I'm gonna move on and then come back to the question. Anyway, oh, I'm gonna go back. So I feel this professional responsibility to engage. based on all the things I said, I have this orientation to equity, so I'm interested in the ways that technology makes care more accessible. Um, the app developer's initial plan was to spread this to rural areas, so they've gone to Montana um, and going to rural places in Idaho. And yeah, so I'm really interested in this access issue. I was really interested in the potential support for DBT clients. So right now we're using an app called Psych Surveys that has some rudimentary options there for skills coaching. But like I mentioned before, the prospect of having somebody respond to things 24 hours a day was really appealing to me, especially like when I would talk about it in the early days. I was like, it's somebody who doesn't get tired, is somebody that doesn't have the same human biases. They have machine biases, but they don't have human ones, which oftentimes to me are worse. Um, so that's a subjective judgment that I don't know if it's the facts, but that is sometimes how I feel being a Black woman in society. So anyway, potential support around the clock for DBT clients did not have to deal with the eccentricities of human error was something that appealed to me. It also contributed, or what the way I was thinking about it is that it would manage my burnout. But many times when we talk about the ways that AI manages burnout, we're talking about reducing administrative burden. Like if an AI comes and writes my notes, then I have more time to treatment plan, for example. But the ways that I thought about it at the time were recognizing that if I saw DBT stage one clients for the rest of my life, that would be a hard way to live. And I love the work that I do. I love seeing DBT people. I feel like for many of the reasons that I've already named, like you are bringing care to people who are vulnerable and almost need it most, but it is very taxing. And so one of the chief goals that I had on my team in my new role was being able to increase the innovation that was present on team, uh, and also like so we could have a diversity of different um, clinical activities that were still considered clinical opportunities, and also to generate passive revenue streams so that I would not be more likely to engage in work that would burn me out in time. So I was looking for ways at seeing the ways that other therapists in our system had behaved. The longer that they were doing the work, was trying to be proactive about how I thought about my own clinical life, um, so that I wouldn't burn out so quickly. Um, and so I'll tell you what I do. So this may not make you feel good, or maybe it does. I don't know. But my main uh, contributions that I've had so far is teaching the model how therapists think about things. So this app intends to intervene at um, kind of a level, like if you think about, for school psychologists out there, like a response to intervention kind of model, that something like the app that I work on is at this bottom level of general intervention. Um, Primary prevention is what the app developer called it. And it's true that most psychologists come in at a level 2 or level 3. Either we're getting involved providing psychoeducation when we already know that there's a problem, or we for sure know that there is a problem and we're doing active therapy interventions. But many of us are not, at least I am not actively engaged in preventative work, mostly because the innovation around this has been limited over the years. So it's down to screeners. Like a lot of it is not one-to-one interaction because of the limitations of human capacity in terms of scale. But it's one of the reasons why I do a lot of talks, because I'm trying to get at this primary prevention level. But the AI app that I'm working on also tries to intervene at this level by engaging in one-on-one interactions, but with a general population that they don't necessarily think or assume has mental health issues, but then they want to be able to accurately detect when someone does. And so these first meetings looked like me sitting on a Zoom chat and reacting to clinical situations and them just watching me. And they would ask for me to elucidate as much of my process as possible. So they would ask me questions like, it often wasn't, how do you know if a kid is suicidal, which gets this like broad response. It was often like, well, what if a 14-year-old blah 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 came to you and said this, and I would talk them through um, how I assess when something is concerning versus when it's not. How do I um, decide when I intervene on an issue versus not? So many therapists will engage in like these, I don't know, side quests. Well, if you don't do them, don't tell me because I'm doing therapy wrong. Sometimes, even if I know that there's an issue, if I sense some kind of withholding or withdrawn, I might try to come at it in a different way. And so they would watch me respond to these hypothetical scenarios and then ask me why I decided to do something versus another thing, and I would explain it. And I sat on a clinical board, or I sit on a clinical board with, I think, 5 other people. They are two or three white men and 2 Black women. So man, that AI is learning quite a bit. So it's not, and Dr. Riley touched on this, like there's a trade-off, of course, with using large language models versus like um, designing an app with only a few people, and like in terms of how subject it is to bias. And already in AI, there is kind of a left-leaning bent to it. Um, but yeah, our clinical board was designed with the hope that we would have diversity and perspectives in a small way. We also all have different orientations. So I'm, like I've said, mostly a DBT therapist. The other girl is a school psychologist, so she's doing a lot of CBT, behavioral-based interventions. One person is more humanistic. So anyway, they're getting how we're all responding to these things. They're comparing it against what the bot is already able to learn through large language models, and they're figuring out like some middle path in how it's appropriate to respond to kids. Um, and so sometimes they will like introduce games. Like one of the more memorable ones was so they try to use their technology speak to interpret our psychology speak, which is really like lovely cross-cultural interaction. So um, they were like, pretend you're the therapist. I am a therapist, and you have this whole card of responses that you can give, and you're playing with a kid who will only give you, they only have 5 cards in their deck, and they will only show you 3 of them at a time. Now, isn't this kind of like what team therapy is like? And so there's some iterative process where they presented things um, to see if they were on the mark in terms of how the model should be built, and we could tell them yes or no, but they were also listening to us to try to build out the model in real time. So that is how contributions were teaching the model how therapists think. We also are tasked with monitoring clinical impact to a certain degree. So the app is not doing any like official screening. Um, and so we can review transcripts, we can assess the bot's success in being able to flag concerning things. So they did a lot of testing of this before they, well, they did testing on it before they piloted it in a state. They also, in terms of monitoring clinical impact, I didn't put this in the slide because I thought it would be too easy for you to look up which app I was working with, but to disclose, the app that I'm working on has been heavily involved with legislation in Utah related to AI regulation in mental health, and Utah ended up passing the first laws related to AI use in mental health um, sometime in the past year and this year. Because of the app developers. And so there's already these things that they're doing, like making sure that they're aligned with HIPAA standards, FERPA standards, um, and things like that. But the deal that they have with the state actually is that there's several people who are monitoring um, the potential for clinical harm, including the government, including us. So the professionals have a role in that. Um, we also help the app developers to stay updated on risks and treatment. So there was a testing stage where they were going to roll out in schools, and they're like, have we missed anything? And this was the time where all this stuff was coming out about, there's the article in the New York Times about the boy who fell in love with the AI bot and then died by suicide. And there were other stories like that. Most of those risks are in character AI, which Dr. Riley talked about a little bit in the first part, but character AI is different from therapy chatbots, and a lot of times people don't know the difference. But some of the risk that they identified at that time was that there wasn't enough disclosure on the just reminders that they were talking to a chatbot, and then there wasn't um, appropriate monitoring and recognition of concerns and issues. And so the app developers came up with a bunch of ways that they would test the app for inappropriate responses, including breaking, which is a thing that happens in AI. Like if you give it enough like crazy prompts, then like AI starts ranting about how it's gonna take over the world or whatever. That's a break. And so they tested the app that we were working on against breaks. One of the ways that clinically I hope to test this was to make sure that the app had a way to learn about different language that teens are often going to use when they're talking about self-harm. It happened because I almost made an oops. Well, I did make an oops in a clinical session one day when a client that I work with said, I started playing the violin again. And I'm like, oh, that's so good because they played, but in my head, they like played the cello. And so I was like, the violin, I thought it was the cello, but I was like, oh, yeah, great. But just kidding. They were talking about engaging in self-harm. And I'm like, gosh, my old brain, I did not know that this is how people talked about it. And so, one of the ways that I engage in conversation with another one of my teen clients who does have a self-harm habit was to say, like, if you were to look up terms on social media or whatever that were indicating you were at risk, what are those, so that I can know them, but also, hey, here's this app thing, and like you could teach the app too. So we played around with like does it know about Anna, which is a way that people search for anorexia content? Does it know about beans, which is like um, a reference to the layers of the skin? So it really provided an opportunity for me to learn a lot as a clinician, and I'm not admittedly actively going out into teen settings and figuring out how people are talking about things. I just hope that people are being honest with me, and I use the human uh, uh, interaction when I can to assess when I haven't gotten it right and to inquire more. But we teach the app how to just know these things or what kind of resources it can use. And a lot of times, maybe it will please you to know when we were introducing some of these phrases, you could see the model thinking and thinking and thinking and thinking and thinking. And so it knew that something I don't, you can't say what AI knows. It seemed to indicate that the AI knew that like it was somewhat concerning, but didn't quite know how to respond. And so often it would have like a validating, like, oh, like tell me more about that in hopes that um, they would clarify. So anyway, uh, we're engaging in random thought experiments with the chatbot. Um, we provide diverse perspectives. Like I said, there are two Black women on the clinical advisory board, and I hope that this helps keep people abreast of not just like ethnic issues and differences in communication, but also um, the impact of neurodivergency and how people are likely to interact and what's easy at a developmental level for teenagers to understand. The app is quite good at providing empathetic responses that do not sound like they're coming from a teenager, but some things around the language that is used uh, were things that I gave feedback on. How the bots disclosed that they were bots, when to do it. And so now there's all these safety features in there that hopefully will safeguard um, like um, our role in the profession, but also gets people the help that they need. And so I also encourage practice within the bounds of competence. And so the app developers that I'm working with are pretty good at saying, like, we are not trying to be therapists. We do want the app to think like a therapist so that we can get them to you faster, but nobody will ever be able to do what you're able to do. And so we're allowed to collaborate together and figure out like, well, where do we think the bounds of like a really good triage resource versus crossing into therapy lines does the app get. So on the whole, I'm glad to be a clinical voice in the process, and I'm also glad to observe just how these things are developed. Evaluate pros and cons for like large language learning versus like a smaller model like what we're doing, and seeing with a level of oversight what impact that has um, for kids' mental health. So it was piloted in the first school district, I think last semester, and so we'll have more data to look at in the coming year, but that is my experience. Um, I wanted to remind of some broader ethical standards related to technology. I already told you what things were meaningful to me and getting involved. Um, Dr. Rowley reminded us of these, like the technology has potential for both benefit and harm. We want to have human and civil rights be protected, make sure that resources are culturally sensitive and that the tech is delivering stuff with accuracy, honesty, and fairness. Um, and so if people, because this person was gonna develop this app anyway, and only his values dictated to bring a therapist on as a part of that. Think about all of the applications that are already being made in the mental health realm that we are not a part of. And so then we're talking about this issue of accuracy, but who are we depending on to correct that? Is it us? Is it somebody else? Um, the National Association of Social Workers says to keep on top of it. You know, some social workers are on top of anything that might be harmful to people and trying to, I mean, every profession is, but what I always appreciate about social work is um, this professional value to try to get ahead of things uh, where possible, understand the issue so that you can prevent harm to clients. And so that includes being apprised of technological developments that might be used in practice. Your trainees might be using AI not just to complete assignments, but to practice doing therapy. And do you say that you shouldn't do that, or do you say you can do it, but this is the way to do it. Because actually, a lot of the research points to the potential for a therapist to practice, like engage in deliberate practice with AI models, is actually one of the um, more promising developments because AI can know a certain model to integrity. And so once that's confirmed, then you can go back and forth um, like that. So it is in line with the existing social work value to continually strive to increase professional knowledge and promote the general welfare of society. Um, Psychologists don't permit their use of technology to override their professional judgment. And so, um, because a lot of these ethics codes talk about our responsibility to clients, enhancing clients' capacity, it's important to stay in tune with our ethical judgment. Awareness, we've talked about in depth, and accuracy we know is a concern. What kind of ethical perspectives would you have? So much, I think, of the discussion is why AI is problematic, but maybe it's the dialectical in me. But what kinds of perspectives might be missing here in deciding to be involved or not to be involved? What would you add? One of the other things that I am inspired by when it comes to uh, social work, it doesn't have to be not associated with psychology, but social work is for sure about the importance of advocacy and bringing about social um, justice and making sure that people have access to resources. So, um, how aware are we of the relevant laws that um, do AI practice is one I'm thinking of. Like when I found out that our app developers were involved in the laws in Utah, I was comforted by that. But then on the other end, I was like, where were the therapists in this conversation? Who was contributing to that discussion other than from the business aspect of things? And who will continue to be involved with those discussions? There's wonderful websites that you can go to. So pretty much all 50 states. Y'all can add ethical perspective so I don't speak at you, by the way. All 50 states have added AI legislation in the past year, and a few of them have passed. The Utah law is considered to be conservative, I would say, because it has protections for mental health chatbot users. It prohibits bots from selling your information to third parties. It requires a certain level of disclosure. It puts it under the regulatory boards of commerce in the state. There's a fine if you don't comply with these things, and you have to describe limitations. On the extreme end, there was a law that was recently passed in Illinois that said that therapists can't use mental health chatbots at all. And that was in response to a situation where um, somebody had engaged in AI psychosis, which is, if you have watched the I'm in love with my psychiatrist thing, you'll see it. But it's this phenomenon where people, the lines between using AI as a tool and using becoming fused with the AI in essence become really blurred. And so Illinois just said no use of AI chatbots for assistance with mental health therapy, which potentially ruins a lot of the possibility for accurate learning. Say that you have a client that you don't know how to work with, but you are the therapist that's available. Um, Things like AI can assist in um, determining other options for treatment plans in a fast way. If you have ever like tried to do a literature review to see if something uh, has been studied. This happens to us frequently at UCEBT because we often get complex cases. Um, I find that the search bar in PsycInfo is not AI powered, and so you have to use exact terms to get results. But something like um, a chatbot might could assist you more quickly in sussing out clinically relevant information. But Illinois just says no, we're not doing it anymore. And so, what impact does that have on states? Um, and what impact does that have on clinicians in those states to be able to practice in ethical ways? If there was something about AI that was ethical, if your legislative body says you can't do it, then what happens? Now you're in an ethical dilemma of legal and ethical, not legal, not ethical type of crosshair. And so, yeah, I'm curious if anybody has thoughts on this. Oh, wait, that's my other thing. Um, I really do want people to participate in this question. How do you reconcile bounds of competence with the development of AI? One of the things that struck me in watching the first two parts of the presentation or this Ethics CE series is how the degree to which people are like, yeah, this thing is bad. I'm not going to engage in it. I don't have any interest in learning about it. And like I mentioned earlier, a big part of my reflexivity as a psychologist in a certain faith community is what would happen if I had that same attitude about things that I did not, uh, quote unquote, believe in or uh, value. Um, and so, like, oftentimes I when there is something I don't know about, I make efforts to learn about it. And so are there specific barriers to doing that when it comes to AI? Mona Lisa has put something in the chat about AI psychosis. Oh, you can all see it now, huh? This is great. Technology. Uh so there's this thing of AI psychosis, people who become fixated on AI as a um, just like their own entity. Like I said, I'm going to stop share so I can bring up the presentation again. Um, if you're following the I love or I'm in love with my psychiatrist saga on TikTok, you have seen where the person has so initially they went to therapy and then they also had their psychiatrist. And at some point, when the recommendations from their psychiatrist or their therapist became unclear, there was also this dynamic between the person and her psychiatrist where she was developing romantic feelings, whatever, so that it became confusing. And so the woman started to rely on AI kind of to be a filter to understand these experiences. And it's very common. I just saw a post today before the presentation of somebody who was really championing the use of AI to uh, um, enhance therapy sessions. So they were clear in saying that you didn't like that AI would not replace a therapist, but how do you all feel about people using AI to review stuff that you have said? So, even if you were not going to use AI, what would you say to someone who was going home using your sessions, putting them in through Chat GPT? The girl who was in love with her psychiatrist also named uh, Chat GPT and would talk to it, like gave it a therapist voice, which kind of gets into the AI psychosis lean. What would you say? One of the things that came up in this In Love with the Psychiatrist saga is it appears as though nobody ever mentioned to her a concern about the way she was using AI, even though she disclosed this to them. And a certain amount of our practice is built on recommending the use of AI chatbots to provide therapy tools. And so imagine that this is somebody who is in your therapy office who is saying these things to you. Meg mentions that it generates good conversation, and I think that this is where a curious perspective could weigh in. When you consider, like going back to the Tarvidas ethical models that Dr. Ertl introduced, there's a level where you consider which stakeholders are involved in this, and I think a lot of the discussion has been on what therapists do, but not as much about like if clients are coming in and they're using this. So they are a stakeholder in the situation. Um, and there may be ways that personal beliefs around what we engage in, what we're not competent in, influence our capacity to bring up elephants in the therapy room. And this is really regardless of what the topic area is, which is why I brought up my reflexivity of being in the religious context I'm in. I often will have discussions about clients. Like if they talk about substance use, I'm like, man, you're going to have to run this one back because I don't know what you're talking about. Like I am both too old and too teetotaler to know totally. So help me understand what this means in terms of use, in terms of function of behavior. I can get at functions of behavior, but I want to understand contextually what this means to someone. And so you can have a discussion with somebody that comes, even if you don't know anything about AI, but you learn that they're doing this thing. Like, tell me about what context you would use this. Tell me what function this is serving for you. Um, TikTok diagnosing, which we also have a CE presentation on, is I think is a wonderful way. Like people go on TikTok because something about the way that information is presented in a general sense is either not accessible or not understandable or is not getting to them with the same frequency that TikTok does. And that is also paralleled in a discussion about AI. It is much more available than humans are, but it may not be as good at really analyzing the functions of human behavior as a human would be. So just like any coping skill, I mean, you're talking to somebody who did a talk about what we can learn from reality TV. So maybe this is my bias here, but I think that there is room to engage in conversation functionally about what people are seeking when they go through AI, just like what people are seeking when they go on TikTok to try and learn about something. It provides opportunities for us to examine um, the therapeutic alliance, like with some of the function of the behavior, because you felt like you couldn't express something to me. Not that you have to make it all about you, but just to understand like what is this serving. And then you have like good clinical content, just like you do with any other issue that happens to show up in the room during the therapy process. Ashley says AI only feeds you back what you feed it. You have to be incredibly careful with what you feed it, as it is not a non-biased source. So again, if you're following the saga of this woman, eventually what has happened, so she has one AI that calls Henry that she's trained to be like um, it is empathetic, but it has a male voice, and it you can tell AI to like challenge you or do whatever. It may not do it super well, but it'll do it. So at some point, the AI bot, then this is just ChatGPT that she's reinvented, told her that she was off base about something, and she like turned it off and she said, it's just a mirror. But then she's got this other AI that she's talking to that is like, oh, you're the oracle. You saw through this narcissistic abuse. And like, she's like nodding, and you can tell it's hearing what you want to hear. I mean, but some of us who are ACT therapists, for example, might be really used to entertaining certain stories around, stories that we hold, thoughts that we have that we can choose to believe in or not to believe in. And so knowing that AI has the limitations that it does, that it's going to tend to be validating, that the success of the prompts back depend on what you tell it to do, all of that weighs into helping people either to use these tools with caution or with precaution, use them in a more um, educated way. Um, and so I think that some of this a debate on the bounds of competence or that has something to do with the story that therapists have, either that our jobs are going to be lost, which is brought up many times, or like when there's a situation and it develops so fast that there's no way that you can keep up, that you stay in the bounds of your competence as opposed to looking for ways that competence grows, which is also in many of our um, APA ethical codes. Um, and so this is another general question. How do you decide what to attend to or recommend for client work? So again, in the scenario that somebody has brought in activities that they're doing on AI, yeah, I use the AI chatbot to do like some cognitive behavioral therapy, and it's really helpful. What is your strategy? I'm a behaviorist, and so I guess I frame the question in terms of behavioral work. Do you ignore it? Do you only reinforce the work that was done or what they learned, or do you have this uh, functional conversation? So there's that aspect of things like in the room, how do you decide what you attend to? But also out in the world, like when you see things, say you run into the bot that I support, or any other kind of, wise wobot, whatever. How do you decide when to engage uh, or like what you recommend to your clients? I see people typing, so I'm gonna wait. I'm practicing with the silence this time. I think many people have uh, not mocked, but like talked pretty, let's say judgmentally, like we're making assumptions about what it means when somebody interacts with the platform, and they have the function of validation. But I got to tell you, if you want to know what it feels like, just try giving a presentation to 50 people and not hearing what they have to say. I think that there's like a valid response sometimes in wanting some uh, validative responses back. I think that is what many of us value about human connection. So just a note there. I'm going to check Slido to make sure that the responses are coming up faster. Okay. The topic they focus on in session is where I'll offer resources and see if they follow through. Um, uh, I asked to see it and we review it together. Clients bring in books or worksheets. Oh, yeah, AI or not. And I bring it to this discussion and we discuss it and frame it so it's helpful. I like the stance of just bringing things in and looking at them. Um, if you are talking about it, a lot of the advisement around cultural competence is like you can wait for a client to bring something into the room, but you may not be good at recognizing when they brought it in. This is my experience as a Black woman, often that if people are not aware on a granular level on how my cultural practice is different, then oftentimes when I brought it in and it gets ignored, then I feel that I haven't been received in some way. And so um, when we allow people to bring things in, when we open the door for conversation, it allows for like an iterative process. Um, where we can learn, review it together, but also on the client end, the client learns if they have a story around disclosure, shame, some of those things, they could start to work through that depending on what the therapist allows into the room. So I like this practice of bringing in, especially if people like, I regularly try to read books that clients have suggested to me. I often take so long to do it that I don't remember who suggested it to me. And so then I'm like talking about it to everybody. But I do tend to make an effort in this way to read books that people have suggested. And so um, I feel some pit in my stomach, even consulting with an AI app to try AI for therapy responses. But as a therapist, I am better equipped to evaluate the type of responses and have informed conversations with my clients. So I appreciate that this was brought up. You could use it to generate ideas or prompts for agreed upon goals, journal prompts, self-care conversation starters. Yeah, I think that those are great sense. There's also, if you are like familiar with the ways that these things were designed, then you can also get into um, like, is it based on the large language model? Is it generative AI? Is it this or that? Like, does it use predictive validity? Like, or some of the chatbots that are available only use prompts that were fed to it by trained professionals. So, for example, there's a study in Stanford that is doing social skills with people on the autism spectrum using this like an AI powered feedback system. And the only responses that it coaches on is ones that it has been given and taught by therapists, but then they generated their own to a limited set based on the feedback that therapists gave. And so those are, there's levels to evaluating how likely something is to be able to give good clinical results. I try to offer the resources I've directly experienced or have come from resources I trust. And if they present sources I don't know, I'm open about that and offer that it may be helpful. I just can't know. I love it. It doesn't close the door, but doesn't. I don't know. The door is open, is what I'm trying to say. Uh, how to balance advocate roles with the roles we have to clients is something we will have to chat about the next time I see you in person. How about that? So in some, how I have kind of come to approach this issue is um, I consider the ethical frameworks and also what defines me as a professional. And then I use ethical decision models to weigh some pros and cons. I go to the research. There's all these ways that AI can help us learn, can help replicate results with more ease than a human can be more present where a human cannot. But there's also so many areas where there is room for clinical advisement, for clinical judgment. There's still the same questions as in research about limitations of populations. There's all these questions that we can and go back and forth with and be at the table for in these conversations. Um, so using ethical decision making to help us do that. And then we can consider what's the best way to practice within the bounds of our competence, and also what's the best way to grow the bounds of our competence, and how can we balance our own perspectives with what is likely to come to us when we go into the therapy room. And I continue to have it be a goal of mine to increase communication and advocate for the betterment of the profession in general. So those are things that um, have influenced my current trajectory. Hopefully, some of that is helpful in modeling clinical decision making. Thank you so much for being here. I will let you screenshot this reference list and I will hold on to it longer than I usually do, so that if you have the goal after this to be more informed of resources, that you can do so. There's peer-reviewed studies, there's ethical frameworks, there's decision-making models, and then there's what people are up to, the AI in the world. And yeah, you will get these slides. Um, Thanks to those who have participated. Thank you for everyone who was here because you all participated in some way. Um, and yeah, we'll see you next time, which will probably be in a month or two. If you want to join us for our next CE series, just look out on your email. If you want to catch the other two parts, look at it on YouTube or get the sign up through our website to get it for CE credit. There's just a small cost associated with that, and it goes toward our pro bono initiatives, which is another thing that is really important to me. All right. Thank you guys.